Fentanyl was designed with good purposes in mind. It has very important therapeutic use, but unfortunately, when it gets into the wrong hands, then it's an extremely dangerous drug to use.
Hello and welcome to the story behind fentanyl. My name is Jess Brady, and over the next hour we're going to speak with area experts on the rise of this opioid across Canada and what efforts are happening locally to help people who use it responsibly and assist those who have a dependency. To start off the program, we'll go to Christine Tillsonburg, who visited Western University's Schulich School of Medicine to find out what fentanyl is and where it came from.
Strongest message I can give is to parents, to the public, is stay away from this drug. This drug is dangerous.
Fentanyl has been making headlines recently for all the wrong reasons. But while these news stories are recent, the drug itself has been around for more than half a century.
Fentanyl was, which was first created in 1960 by a guy called Paul Janssen in Belgium, is used for pain relief. So it's used primarily as an analgesic or pain relieving medication, much like morphine is used.
Fentanyl is 100 times more powerful than morphine and is designed for very specific medical purposes.
Fentanyl is given kind of to two kinds of patients. It's given acutely, so in settings like the operating room or the emergency department. There's also slow release patches given for things like pain relief over a long period of time. But in that case, the fentanyl is given typically as a patch on the arm because it's released very slowly over a long period of time.
Fentanyl can also take the form of a powder or pill, but it's never dispensed that way. It's too difficult to control the dosage. Used properly, fentanyl is a swift and effective painkiller.
Right, so fentanyl rapidly is going to enter the bloodstream. It's going to interact with what's called mu-opiate receptors in the brain. So these are receptors that are found in areas like the brain's reward pathway, which is obviously involved in addiction. It also interacts with the body's pain processing system for analgesia. So of course it's commonly used as an analgesia, but it also has very highly euphoric and reward-producing effects that can lead to dependence and addiction.
The drug is so powerful, it's dispensed in micrograms, thousandths of a milligram.
Well, the main problem with fentanyl is that because it's so potent, and especially in transdermal formats, this requires very careful monitoring by the doctor. And it is a very effective drug for the use of pain management and palliative care, but if it's not supervised, it's very easy to overdose.
That's where the negative headlines come in. When this drug is misused, the results can be devastating.
So the question might arise, why don't we just ban fentanyl altogether? The answer is it's a useful drug. I mean, if you're an anesthetist who wants to give someone a very potent drug that works quickly, fentanyl's a good drug.
Fentanyl was designed with good purposes in mind. It has very important therapeutic use, especially for chronic cancer patients that are in palliative care. It can be very helpful. But unfortunately, when it gets into the wrong hands or when it's not administered in a therapeutic setting, in a clinical setting, then it's an extremely dangerous drug to use.
For Rogers TV, I'm Christine Tillsonburg.
I'd like to now welcome Lisa Gillespie. She's a public health nurse with Oxford County Public Health. Hi, Lisa. How are you?
Hi, great. Thank you for having me.
Thanks so much for joining us. And, you know, as we can see from that, from the story that was put together by Christine Tillsonburg, this opioid, fentanyl, it's versatile. It can come in a lot of different forms, but it packs a punch. And we've heard across the country stories of the rise of this opioid, specifically out in BC and Vancouver. You don't necessarily hear about it so much in Oxford County, say in Woodstock, but certainly it is an issue there. Talk to us a little bit about the difference between what we're seeing in BC and what we're seeing locally here in more rural communities, if you will.
Sure. So as you said, opioid addiction is a problem all across Canada, and Oxford County certainly is not without its concerns. We know that through our needle exchange program here that our #1 drug of choice is opioids. And our first drug was OxyContin. And when it was delisted in 2012, the hope was that people would transition into treatment, which many people did, but then many people transitioned into more dangerous drugs such as fentanyl. We certainly see some people misusing fentanyl here, but probably the #1 drug of choice right now is hydromorphone. But I think we'd be naive to think that it isn't coming here.
It's true, because it's been sort of a creeping rise. You know, we saw some of the stats in Christine's piece there talking about rates more than doubling between 2008 and 2012 in terms of fatalities. So it seems to be a slow creeping thing, and then all of a sudden it's everywhere, as you've seen in the headlines from Vancouver and other communities out west. For anybody who doesn't have a lot of exposure to addictions and the related issues, addiction may just seem like a simple thing. Well, you know, just stop doing what you're doing. But really, it's very complex. It's not just a simple issue. I mean, there's a lot that goes into it. And so, you know, the folks there in Oxford County, they know a lot about how to fight this sort of thing and help people with the 4 pillars of addiction.
Absolutely. As you said, addiction is very complex, and the reason for people to become addicted is very complex. So it's going to take a very comprehensive strategy to deal with the issue. So the 4-pillar approach looks at prevention, treatment, harm reduction, and enforcement. And we all need to work together in order to tackle this very complicated issue.
Certainly, and luckily there are a lot of different partners that are working here in London and Oxford County, of course. There must be a great deal of communications between you and the other agencies. What's it like trying to work together to find solutions?
It's really vital that we're all on the same page, and we all come at the issue from different angles, but we're all on the same side, and we want to keep people as safe as possible. So I'm part of the Oxford Drug Awareness Committee, and we have police, we have treatment people, we have harm reduction people, we have mental health people, all working together in order to tackle the issue and keep our citizens as safe as possible.
It's true, and I think sometimes that people don't realize the types of services that are available to them, right? So sometimes, they could find themselves in a problem, or they have a friend or a significant other, family member who is in trouble, and they don't know where to start. But clearly there are options and ways for people to get help.
There are options and ways for people to get help. Certainly living in a rural area adds certain challenges, such as accessing services such as detox or rehab. Those aren't available in Oxford County. Transportation is another issue. So, for instance, if somebody wanted methadone, until recently, people would have to find their way to Woodstock to get their methadone. So they'd need transportation. Another concern is anonymity. So people are afraid to reach out for help because of the stigma around addiction, and maybe are feared that they might know somebody working there. So I think probably the most important thing here is to keep this conversation going and to address the stigma, and the fact that it's a medical concern. Addiction is a medical concern and not a moral one, so that people feel comfortable to reach out for help when they need it.
Talking about that, the whole factor of anonymity was my very next question for you, had you not so adeptly jumped on that one. Because it is true. I mean, in a larger city center, you do have a little bit more anonymity. If you're going to a clinic, you're not likely to necessarily run into someone that you know. But in smaller communities, they're very tight-knit, and that can be a real issue. And I also like the point that you made about focusing on this as a medical issue, not a moral one. People can fall into addiction and dependencies for all sorts of reasons. You could have suffered an injury and then been prescribed this medication, and you become dependent on it. It doesn't really matter how it began. It's about getting you help to get off of it, right?
Absolutely. Yeah. Absolutely. People get addicted for many different reasons, whether it's trauma, neglect, filling an emotional void. They might be prescribed because of an injury and then become addicted for whatever reason. So that's really not important. It's about meeting the person where they're at and treating them in a respectful manner and getting the help they need at whatever stage they're in.
Certainly. And, obviously, to go back to the differences between urban centers like Vancouver or even London, as we're starting to see the rise of it here as well, and the more rural areas, there are going to be challenges with both, right? Because in the urban centers, you're dealing with a mass population. Yeah. So getting the right resources for those individuals is tough. And even in the smaller level, it's harder because it is a smaller area. So it's really the grass is greener in some ways, isn't it?
Yeah. Exactly. They both have their ups and downs. I think one of the good things about a small region is because, like with the Oxford Drug Awareness Committee, we all know each other. We're often dealing with the same clients, and we have good communication and know each other very well, so we can work together much easier, perhaps, than a bigger center. But at the same time, there are other challenges that I mentioned, such as access and transportation and the anonymity. So there's good and bad with both.
Certainly. Do you find that it's maybe a little easier to come up with locally grown solutions? Like, are you able to brainstorm more and have a bit more freedom to implement something on the local level?
Absolutely, and one great example of that is the Oxford Addiction Treatment Strategy. So it's basically a group of concerned professionals that came together from the Ingersoll Nurse Practitioner-Led Clinic, Addiction Services of Thames Valley, the Community Health Center here, and they're all working together and sharing schedules and working together to get clients into treatment as soon as possible. So that's a great example of that.
Fantastic. Now, we want to talk more with Lisa, but first, John Payne talked to Sergeant Chris Auger from the OPP Drug Enforcement Unit here in London about a grassroots program that's helping our control in the communities.
In 2016, October 1st, the Patch for Fatch program actually became legislated as law here in Ontario. So basically, it's now a law as opposed to a voluntary program that once we sort of set up in Oxford County, in various counties, I think 13, 14 counties across Ontario. Anybody with a prescription of a fentanyl in Ontario will have to return those patches to the pharmacy for proper destruction as well, somewhat of tracking to make sure that we have these narcotics, these powerful narcotics, being able to returned and being used therapeutically as it's supposed to, as opposed to being used off-label with people cutting it and people doing those things. If that does occur, it'll be a conversation between the pharmacist and the doctor to sort of see what they would like to do about that if people are misusing the patches. If it's a fraudulent in nature or anything sort of that could be in the bounds of criminality, then the police do get contacted by the pharmacy or the pharmacist about the possible diversion of these drugs back in our community. I think just like any sort of great plan, there's always going to be counterfeit patches that show up. There's going to be people that try to divert around the system. There'll be people that say they lost patches. Sometimes that might be an addiction-related issue. That might be something that they're sort of snorting or they're smoking the patches or they're doing something improper to actually use it therapeutically. Other times we've seen major cases. There was one in one that's in Gananoque right now that's being processed where a large number of fake fentanyl counterfeit patches were found on return sheets, and we're starting to see that as well. We use the term we can't arrest our way out of the issue, and that's truthful because I mean we don't have enough officers to be able to sort of maintain all those checks and balances, and as well it's a community issue where there's abuse deterrent. How do we, somebody that's dealing with substance abuse issues, is that person properly funded towards going towards a treatment center? Is that person, should that doctor be more cognizant of it? And it is a grassroots procedure that worked out really well. Like somebody came up with the idea of, hey, we can return these. And it's almost that common sense idea that sort of takes root, and then different communities said, yeah, why are we not doing this? Well, the amount of presentations we do and education to the public is a very important component that we sort of do. But through that education too, we confer with our community partners, because there's sometimes we're not the area experts on, hey, how is this sort of script being written right now? Is there new terms you're putting upon it? Is there new, what would be the standardized dose? What was the legislative changes that happened with various programs, like the Ontario Drug Benefit Plan? Just like anybody else in Ontario, we're preparing for what could eventuality be, bootleg fentanyl being more prevalent in Ontario. Still in Ontario, the majority of the prescription opioid or the opioid overdose deaths that happen are still prescription drug related. To this point, we've not seen to those extents that we've seen out in BC, obviously, where it's sort of hit an academic or epidemic type status out there. We are seeing more in Ontario. We're preparing with our other community partners, and there's a opioid overdose coordinator with Dr. David Williams that's being applied with the Ministry of Health, and he's coming up with strategies to help the various Ontario communities deal with emergency situations that deal with synthetic opioids or opioids in general to help out. So there is plans, there is people sort of working on these issues that sort of that is going to be, again, more community based. I mean, it's not an easy issue to sort of deal with, because you are dealing with illicit product when it's sort of put that way, as opposed to a prescription product, which is diverted but you can track it electronically. You can take a look and see from the various systems. But with this, it could be something that's ordered in from another country, sent through mail, and sort of produced that way. So that's sort of what we're preparing for.
Thank you very much for that. Lovely to hear from Sergeant Auger and John Payne, who put that package together. We will now be rejoined by Lisa Gillespie, who is a public health nurse in Oxford County. Lisa, thanks for joining us again and for taking part in listening to that package there. Something that I found really interesting was the discussion of the Patch for Patch program. What's your experience been like with that? I mean, it's kind of an ingenious way of making sure that people are staying on track with the patches.
It's a great example of a harm reduction approach and a prevention approach to misuse of fentanyl patches. And I was involved with Chris and other community partners in Oxford County bringing that program here. So yes, basically people, in order to get more patches, have to bring their patches back to the pharmacist. And in Oxford County, we were proactive and got this program going before it was legislated, but now as of October 2016, it's actually legislated, so all jurisdictions have to do this program.
You know, some people might say, have that mentality of, geez, it's come to this sort of a thing. But I honestly think, like you said, it's harm reduction, and it's being proactive and finding a creative solution to a problem, right?
Absolutely.
Because so often, like with fentanyl, I mean, it was created with good intentions, as we saw at the beginning of the program. But sometimes there are unintended consequences, and you have to be able to address those on the fly. So it's an interesting way of doing that and helping people stay on track.
Yeah. Absolutely. And we have a huge problem with opioid addiction in Canada and in Ontario. So that's the situation we're in. So we do have to come up with good strategic plans in order to deal with that. We can't just leave people addicted. We hope to prevent them from becoming addicted in the first place. But if they're in a place where they're addicted to a substance, we have to help them with treatment or harm reduction, whatever we can to get them to that next stage.
Certainly, and you know, it's interesting that you, the way you talk about the stats for the province, and I feel like it's becoming more and more part of the public consciousness, because when people now go for a surgery or they go for treatment of a medical issue and they're prescribed an opioid, whatever kind it may be, they're a little bit leery, they're a little bit wary of it, and they almost try and regulate themselves, right? Because they say, okay, they've given me so many pills or so many patches, but I want to make sure that I don't fall into a trap of being dependent on it. So there is a little bit more of that, self-education in a way, and
really important.
Just being nervous about it, eh?
Yeah. Education is power, and that's part of the prevention piece. And really, just because it's a prescription, you have to take it the way it's prescribed. And the opiates do have a place in treatment. But it is important for people to be wary of them too, and use them appropriately. Don't use them with other medications. Don't use them with alcohol. Don't take an extra one because you're having extra pain. Always check with your doctor first. It's really important, because addiction is a potential issue if you start using it as it's not prescribed.
Certainly. And you know, Lisa, this is something that we've seen with other drugs like Oxycontin. When the issues and the problems started to outweigh the benefits of the drug, they've been phased out. There have been different drugs that have been put in place and just phased out completely in some cases, like Oxy. Do you think the potential for that with fentanyl, or is that too soon?
I think fentanyl is a good drug, and I think the idea of taking Oxy off the market, I understand why they did it, but at the same time, people are still addicted. So if they don't have treatment options, or maybe aren't in the stage of readiness to address treatment, they're going to be looking for those drugs somewhere else. It's not going to take the addiction away just by taking the drug away. So that's, again, why we have to have a comprehensive strategy looking at all 4 pillars in order to deal with the issue.
It's true, because we did see that transition of people moving from Oxy to other things when it was phased out, right? So as you say, it doesn't solve the problem, it just kind of displaces it in a way.
Yeah, exactly. And with bootleg fentanyl potentially coming on the scene that could fill that gap of prescription fentanyl, like, we have to be prepared for that possibility.
Certainly. Now, Lisa, we talked a little bit about this before we saw that last package, about the differences between the urban areas and more rural areas, say in Oxford County. But specifically, BC is really struggling. We hear reports now in the national headlines of a record number of overdose deaths and things of that nature. Let's talk a little bit about the differences between what they're going through in BC and what's happening here in Ontario, because we're not quite at that crisis state. It's still kind of a developing situation.
It is, but I think it's important for us to be proactive because we do have an opioid addiction crisis. It is possible that bootleg fentanyl could take hold here, and we have to be prepared. But opioid overdose and misuse is certainly not new to Ontario. Perhaps the drug isn't bootleg fentanyl at this point, but we have to prepare for that possibility, and about naloxone and increasing access to naloxone. So that's another strategy that can be used in order to address. Hopefully we don't get to the point where they had in BC, which is a tragic situation. So I think for us to be proactive is really important.
Absolutely. And, as you say, education is key, and being proactive also key. Yeah. If there is someone who, if you think perhaps there's something not well with them, maybe they were prescribed some of the medication and you're noticing a change in their behavior, what can people do to kind of, help those in need or their loved ones who they think may be entering into a bit of trouble?
Yes. So reach out for help. There's people out there to help you. Don't be embarrassed. It is a medical concern, and there are people that care and really want to help their loved ones or the person themselves. I just hope that people feel comfortable to reach out for that help because it is there for them.
Absolutely. Lisa Gillespie from Oxford County Public Health, thank you so much for your time today.
Thank you so much for having me.
It was a pleasure chatting with you, and we learned a lot, I think.
Thank you.
And now, Lisa, to carry on with what you were saying, there are resources out there, and our aim today is to educate and provide as much information as possible to the community. So we have some information about community groups in the different communities around this area, and that way if you find yourself in a situation where you'd like to help someone else or you yourself need a little bit of help, you can contact these agencies and they will be more than happy to guide you in any way that they can. Canadian Mental Health Association has a mental health and addictions crisis centre in London, 519-434-9191. And in Woodstock, they also offer walk-in counselling Tuesdays at the Oxford Elgin Child and Youth Centre on Dundas Street. And on Thursdays at the Woodstock Hospital at 310 Juliana Drive. Also in Woodstock on Saturdays at the Canadian Mental Health Association Woodstock office on Peel Street. In Tillsonburg, Mondays at Tillsonburg Campus of Care. In Ingersoll, Tuesdays at the Nurse Practitioner-Led Clinic on King Street East. For residents in Elgin, more information can be found at cmhaelgin.ca. Those seeking services in Strathroy can go to cmhamiddlesex.ca. And for those looking for services in Exeter and Goderich, you can call 519-235-0335. I'd like to now welcome Blair Henry, who's a harm reduction case manager with Regional HIV/AIDS Connection here in London. Blair, thanks so much for being here.
Oh, my pleasure. Thanks for having me.
So when we talk about Regional HIV and your role there, what exactly do you do within the organization?
I work with the Counterpoint needle syringe program. Mm-hmm. And this is a project of Regional HIV and AIDS Connection in which people can come in and access harm reduction materials such as syringes and cookers and anything to make a practice, if they're an injection drug user, able to make that a little bit safer. Mm-hmm. And so we do that. And then if somebody is asking for, saying that they want to make a change in their drug use, mm-hmm. then at that point, then I step into a sort of a separate role where I say, what does that look like? And then we can actually counsel them to either reduce their drug use to an amount that's more manageable for them, or abstinence entirely, mm-hmm. or changing to perhaps a different drug that's less harmful for them. Mm-hmm. So, and it's a program that means that in Counterpoint we have 80 to 100 visitors every day.
Wow.
Clients every day come in, and we're the second busiest needle syringe program in the country after Vancouver, and we actually we give out last year 3 million sharps. So
Wow.
it's a service that is very, very frequented by the population of London.
No kidding, and I think people will be very surprised to hear that, second largest in the country behind Vancouver, because you often hear stories about Vancouver, and as I was saying with Lisa Gillespie from Oxford County, there's a big difference between problems faced in Vancouver versus in smaller centers, but it's not that different, really.
Well, we have a great number of intravenous drug users, and I think that's partially a testament to the city and the amount of really quality support workers and social services that there are in the city, that people who are street involved tend to perhaps come into the city because they know from the surrounding counties, because they know that there are support services for them.
Right, so it acts as a bit of a hub then.
Yes,
Yeah.
absolutely.
That's really interesting, and something that I'd like to pick up on a little bit more is that counseling aspect that you do when people say they're looking for a bit of a change. What's that moment like when someone comes to you and says, listen, I have a problem and I want to start making steps towards fixing it or helping myself a little bit more?
Well, first of all, it usually doesn't come that abruptly,
Yeah.
with it. It's people will often just say as they're in the exchange, I'm sick of this, I need to make a change. And at that point, I will never bring up the topic of change for somebody until they introduce the topic. And that's really an important thing, because there's a trust that's built that I'm going to be non-judgmental. We have a real belief in kindness in dealing with our clientele. Are the most wonderful people that I just feel really privileged every day to get a chance to work with them. And our clientele, they come in with a huge amount of problems, and everywhere they go in the city, they're kicked out and chased away and all that. So when they come into our services, they're actually greeted with love and kindness and acceptance in a non-judgmental way. So when somebody actually says, I'm sick and tired of this, I need to make a change, then I will softly just say, so is that something you want to have a talk about? Or what does that look like? And then they might say, I just need to change from one drug to another or something. Do you have a plan? And so then we'll go into another room. And one of the things that I really make clear is that at times with addiction, your mind changes. What seems like a good idea in this moment is not a good idea in the next moment. So we'll see that they will come in, have a talk with me, and decide that was a bad idea. They don't want to change. They're totally okay with their patterns as they stand. They were just having a moment of weakness, perhaps, they were feeling. And so the next day, when they come back into the exchange, I won't bring that conversation up to them, because I don't want, if you're an injection drug user, there's a lot of people that you feel, you carry a lot of weight with that, and there's a lot of feelings of judgment, and you've disappointed perhaps family members and a number of other people, and I don't want to be part of that situation. I want to have them come in and know that they're going to be unconditionally accepted, and that we're going to help them incrementally be a little bit safer and a little bit better.
That's a fantastic process too, and it requires a lot of patience on your end, right? And commitment to that process, and it's obvious that you have a lot of passion for it.
Oh, I do. And the other thing is it makes this incredible amount of economic sense too. And so if someone's to get HIV from injection drug use, it costs about $1.3 million over the course of their life to treat that infection. If somebody's to get Hep C, we've got fantastic new drug protocols for Hep C, but it's very, very common amongst the intravenous drug using community. And that costs about $100,000 for the medication, plus the testing and all the rest, about $300,000 in total. Our services for Counterpoint, it costs us $500,000 a year. So if we can divert one person from getting HIV or two people from getting Hep C, and we know we have a much greater impact than that, then that economically has paid for our services. It saves the healthcare dollars.
Totally.
But more importantly, it's about treating people as humans and with dignity and respect that we all deserve.
Absolutely. And now part of that process of, helping to reduce healthcare costs and in turn helping people stay healthier is the antidote to fentanyl, if you will, naloxone and other opioid drugs. And that has been just, in some cases, described as basically a miracle drug and how it helps people recover from an overdose situation. Can you first explain naloxone a little bit to make sure we have a proper understanding of what it does, and then the kits that are available through regional HIV?
Okay, it's a great question, because opioids, if you're an injection drug user and you've put opioids in your system so that you've shot up, or you've had a fentanyl patch or something like this, but let's say you go into overdose.
Right.
What that means is you've got opioids going through your blood system, and they're floating through your blood system, and you have receptors on your brain. And those receptors, those opioid receptors, the opioid attaches to them, and when they get all filled up, you go into overdose, and that means you pass out, your breathing becomes labored or it could stop. There's many different symptoms there. Naloxone, it's currently in an injectable form, but very, very soon we'll have a nasal aspirant that we'll be able to use. But the injectable, when you inject somebody with naloxone, it makes that receptor like Teflon. And so the opioid falls off the receptor, and allows the person immediately to sit up, and they are someone who's in full overdose, they're unconscious. When you hit them with naloxone, they will sit right up. And the bad part is they become pill sick. They're in immediate full withdrawal. And so very often they're upset that you just took their high away from them. But what happens is that opioid is also still floating in their system. And the important thing about naloxone is to remember that it lasts for about 45 minutes to 90 minutes in your system. And so that means that after 45 to 90 minutes, that Teflon falls off, and the opioid that's still in your system can reattach. And you can go into overdose again. So if anybody uses the naloxone, it's really important to get EMS there immediately after, because that person is still at risk of going into overdose again.
That's really interesting. And now we've talked about the change in the kits that's coming, and that's happening this week, actually.
It is. We're really excited about it.
Yeah. And what's the difference between, or I guess maybe the advantage of the nasal spray versus the injectable naloxone?
Well, you can imagine if you are, first of all, the nasal spray is really, really easy to use.
Okay.
I just have to, if somebody goes down, it's just like a spritz up their nose, and your spritz is quite powerful, so it can overcome any blockage.
Right.
And it's also very powerful. And the person, as fentanyl and other drugs start to come more and more available, we need more and more naloxone in your system to counteract it.
Right.
And so it's, so with the nasal spray, it's actually 5 times more powerful than the injectable, which was what we're currently using. And so it's much more effective. So you might have to actually hit someone, inject them twice with naloxone with the injectable.
Right.
But the new kits, which we're expecting to have available for people by the end of this week, it's handier, it's easier to use, it's more powerful, more effective. It's a win-win in all situations.
Totally. And I would also imagine this goes hand in hand with what you're saying there. The fewer needles that are out there, and that some people might be nervous about using a needle to inject someone with a naloxone. I mean, it just makes it a little bit more accessible. Having a nasal spray, it seems a little less, off-putting perhaps to someone who is, although medical professionals who are administering this sort of thing, they're not going to be fazed by that at all. But for somebody in the public, it would be a little bit easier.
And if you have somebody who is an opioid user that you know or is in your family, it's a really great idea to come down to us or go into a pharmacy and get a naloxone kit. It's just a matter with the mix of drugs that are available on the market today. We're seeing people put fentanyl into other drug mixes right now.
Right.
And so we're never quite sure what's being used. So if you have somebody in your family, and the fact is you do, have somebody who is a user of drugs, we want to make sure that you are able to save their lives, because there is no recovery in death. If that person doesn't make it through the overdose, their chances for living a fulfilling, great life is now passed. So.
And with the kits, just to stay on those, like you mentioned, you can go to Regional HIV Connection, you can go to a pharmacy.
Yeah.
How much do they cost to pick up one of those kits, or is it how accessible is it really?
It is so accessible that I'm going to give it to you free. So it's and the pharmacy as well. It's a free kit, and the training for if you were to come down to us, it'll take you 15 minutes to train through the procedures.
Fantastic.
And I'll tell you that we in London we know of at least 13 lives that have been saved by the naloxone being administered, and those people now have a chance to make changes if they desire in their lives to live a positive life.
Amazing. And now we are coming up to the end of our chat with you, but we've talked about the wonderful atmosphere that you guys have at Regional HIV Connection, and it's, you can come in judgment free. How really important is that lack of stigma within your community? How would you like to see that extend to elsewhere?
Do you know, nobody that I know of has ever written in their high school yearbook that their ambition is to be a person who injects drugs and live on the street. And we have to recognize that the people who we see who are ending up using a lot of injection drugs have got a great deal of trauma in their background. It's a mental health concern. This is not a moral choice. This is a mental health issue. And as a society, we have no mental health supports, very few mental health supports right now for those people. And we'd like to see that addressed and changed. And we're actually working as a community to do that.
Certainly, and I'm sure that the more we talk about it on programs like these and others, that will continue to bring the issue to light. And as Lisa was saying before, and as we've said, it's a medical issue. It's not a moral one.
It's absolutely right. It's a medical issue. It's a mental health issue. And you might have, I don't know whether it's smoking or chocolate or what, we all have something that we soothe with. Yeah. And this just happens to be, an opioid is something that soothes, and it's often a result of a doctor prescription as well. We've had doctors over-prescribing some opioids for quite some time, and so now we're starting to see that lessen, but there's still a backlog that we have to deal with.
Certainly. Well, Blair, thank you so much for your time today and for sharing your experiences and the work that's going on at Regional HIV/AIDS Connection. We really appreciate it.
Thank you so much for having us. Thank you.
Well, we need to throw to another package put together by the lovely Christine Tillsonburg. No one knows more about the impact of fentanyl in London than our first responders. Christine talked with police, EMS, and pharmacists to find out how serious the problem is in our city.
Yes, fentanyl has arrived in London. Last year in 2016, we had 4 confirmed seizures of powder fentanyl. Also in 2016, we had 7 deaths that were related to fentanyl, and we have 3 other deaths that we suspect are related to fentanyl, but they are still pending the toxicology from Health Canada.
At Middlesex London EMS, fentanyl is already a household name.
The whole premise on narcotic overdose and fentanyl overdose have really been around for a long time, and it's nothing new to us. In fact, our paramedics have been carrying the antidote, or Narcan, for over 15 years.
What is new in London is a dramatic increase in fentanyl-related crime.
In 2014, we had 4 robberies that were related at pharmacies. In 2015, we had 6. And last year we had 18. And in all those cases, they were related to the suspects coming in looking for illegal narcotics or fentanyl.
Turner Drug Store on Grand Ave was one of those pharmacies. They were hit by an attempted robbery on December 27th.
2 gentlemen, we'll call them, came in the store and said, "Give me drugs, give me drugs, give me drugs." They came in, they surprised me, they startled me, and I just reacted and just said, in fairly colorful language, "No, you're not getting any drugs, go away."
It was the first such incident in more than 4 decades.
There haven't been any attempted robberies, and I've been here since 1974.
Turner Drugstore only dispenses fentanyl slow-release patches. Police say the powder form of the drug is often imported from overseas or produced locally in clandestine labs.
The challenge is the users of fentanyl, sometimes they don't realize what they're getting. And they may think that they're taking some other type of illegal drug, and they don't realize that it's been cut with fentanyl. And in many times where we have overdoses, for example, someone could be taking an imitation pill that may contain fentanyl in it, but if it has not been mixed properly, that person could have half of a pill one day and be fine, but take half of a pill the next day, and it may have a stronger, what we call a hot spot of fentanyl contained in it, and that may result in an overdose.
This is our symptom relief kit that our paramedics use, and Narcan is positioned here. The usual dose for Narcan is 0.4 milligrams, which is normally enough to boost up someone's respiratory rate.
Middlesex London EMS has seen an increase in the number of times they have administered Narcan, also known as naloxone, from 28 times in 2013 to 38 times in 2016. But so far this year, it has only been used twice. Back at police headquarters, they aren't taking any chances.
What people don't realize is fentanyl can be absorbed through the skin, and just very small traces amounts of it can cause serious injury.
London police have invested in specialized equipment to protect officers from accidental contact with powerful drugs like fentanyl.
No, absolutely, it requires special attention. It is something that we are very concerned about here, and that is why all police agencies are taking steps to, improve the officer's safety and also try to keep the public safe.
And like many pharmacies, Turner Drugstore also has security measures in place.
We have our little panic buttons throughout the store, and we do have video surveillance. We're well prepared, but I don't think, going to work every morning, it's always in the back of your mind, but I'm not letting it color my world, so to speak.
For Rogers TV, I'm Christine Teleski.
I'd like to welcome Megan Van Bohemen now, who is an addiction and mental health counselor from Addiction and Mental Health Services of Thames Valley. Megan, thanks so much for being here.
Thank you for having me.
Now, we have spoken with a number of people over the course of this program, and we've touched on it a little bit, but addiction itself is not just drug usage and right. the constant usage of it or what have you. It has a lot of offshoots and impacts on a person's life, social, family, all sorts of things. Mm-hmm. And with the organization that you're at, how does the agency try and help people through that? Maybe tell us a bit about those consequences of addiction and how you try and help people.
Yeah, so I work with Addiction Services of Thames Valley, and a lot of times the counselors would laugh if they heard me say this, because we use the iceberg analogy where we say, the addiction is the tip of the iceberg. That's what you see, and that's about 15% of what's actually going on. Right. And what's actually going on underneath the iceberg is where we want to focus, and that's the reasons that people do use. The reasons that people do use can be related to issues of shame, of guilt, past trauma, anything like that. So we know the addiction itself is a small part of the problem. What happens is the addiction can take over a large part of their lives. So it can mean ruined relationships with family members, with partners. It can ruin job opportunities. It can cause difficulties at school for young people. Because when addiction, especially when it comes to opiates, what I've seen with a lot of people I support is that's your priority. Every day your priority is, what am I going to do today to make sure I get my fix so that I don't get sick, because the withdrawal with opiates is unbelievable. Mm. So, school isn't necessarily a priority. Paying your bills on time isn't necessarily a priority when you're really trying to avoid that horrible, awful withdrawal feeling.
And it's really easy for things to spiral out of control, right? And so often people may end up homeless for different reasons, right? And so when you see someone who has an addiction and maybe they're on the street, it's not as simple as that they want to be there or they're not trying, because right. they have so many issues that they're trying to juggle and to find a way through, a path forward, right?
Yeah, absolutely. And this is a large part of my job, I feel, is we we deal with stigma, and we really try to eliminate stigma, because stigma hinders change. And when people feel shameful and they feel like they need to hide, then that really does hinder that change opportunity. When you see somebody, you know, on the street that may be homeless as a result of their substance use, that's not a choice they made. I've not met one person yet that I've worked with as a counselor who said, you know, when I was 10, I wanted to grow up and I wanted to become addicted to substances. Right. Nobody makes that choice, right? Things happen in life, and situations come up that are kind of beyond your control, and this is the situation that they're in. Sometimes it can feel like there's no way out. Sometimes it feels like there's no support. A lot of times bridges may have been burned with organizations or with family members that are no longer a support. So it can feel very isolated. And like I said, a big part of what we do is eliminating that stigma and letting people know that change is possible, and that if they come to our agency, that it's going to be a non-judgmental approach when we meet with them.
And that's so important, you know, as we were talking with Blair from Regional HIV AIDS Connection, it's saying that making that space a safe one, because in many other areas in their life, it may not be safe, and people are not the most judgment-free, if you will. Right. So what types of services, what does your agency offer? Like if someone comes in and they say, you know what, I'm thinking about making a change, or I need some support, what sort of things can you help them with?
Yeah, so we work from a stages of change model. So we don't have, a lot of agencies or, you know, different programs can work from an abstinence-only program where the rule is you don't use to come in, that's the bottom line. Whereas we kind of look at where someone is on the stages of change. And if they're at a position where they want to keep using, but they want to use safely, then we're going to use a harm reduction approach with them. Right. We meet them where they're at. We don't put our own expectations on where they should be or what their recovery should look like. If they do want to achieve abstinence and their goal is I don't want to use at all, then we can support them with that. We have several different programs at the agency. I'm part of the COPE team, which stands for Community Opioid Addiction Program. We have a Heart Space program, which is supporting pregnant and parenting women, and there's an Internet Gaming Disorders and Problem Gambling Services program as well. We have a Fresh Start program that's connected with Ontario Works, and we have a telewithdrawal and crisis support program with some registered nurses. So there's a wide range of what we can offer. If someone is coming in and looking for support, our walk-in intake is where they start. So walk-in intake occurs Monday and Thursday in London between 1 and 4. And I know I sent some information, hoping maybe we can share it at the end about, because we do have walk-in intake services in Oxford County and Elgin County as well. So people start there. There's an assessment process, and they would be connected and triaged with the right counselor, because we want to make sure if your problem is opiates, then you should be with an opiate counselor who really knows what they're talking about with opiates.
Exactly, yeah.
Right?
Tailor it to the individual.
Yeah. And then another part of our job too is occasionally people will seek a referral to a residential treatment service. So Addiction Services of Thames Valley is a community treatment program, which means that we work with people in the community. We can also act as a referral agency to refer to residential treatment programs, which there's many that are OHIP funded across the province, and we can facilitate that referral and send that off for folks.
Fantastic. So there are a lot of moving parts in terms of what the agency does, which is fantastic. Now, something I wanted to pick up on when you're talking about harm reduction and people who are wanting to look towards a change, and perhaps incrementally so. We talked before about naloxone, which is the drug for the immediate emergency situation to help someone who is in an overdose situation. Right. But something else that we haven't talked a ton about yet is methadone and Suboxone. And those have very important roles in terms of helping people overcome addiction and move through it, don't they?
Yeah, absolutely. So methadone and Suboxone are what we call opioid substitution therapies. And they are opiates that are prescribed by a physician that can be taken daily to manage the withdrawal symptoms and work toward a goal of being off of opiates completely. So they're two different, methadone has been the standard in Canada for a long time, and it's a drink. I'm sure a lot of people know what it is. Methadone is an opiate itself. Suboxone it's been the standard in Europe for a while, and it's just kind of becoming the big thing in Canada. And it's a different opiate because it's called a partial agonist, and I'm not going to get into the science of it, but the way that it works is it kind of binds to the opioid receptor in a different way that can be protective to the person and prevent an overdose. And it doesn't really allow other opioids to get into the system. And it gets a bit complicated, but the big differences I notice, methadone, there's a higher overdose risk because of the type of opioid that it is.
Right.
So because of that, it takes a long time to earn carry doses or take-home doses. You have to go every day to the clinic and get your drink. Suboxone has a lower risk for overdose, so you can earn those carry doses a lot quicker. So that means, and Suboxone, you can go get it at Shoppers, Rexall, any pharmacy. It doesn't have to be a specific clinic. As well, family physicians, most doctors that are in good order prescribing can prescribe Suboxone, whereas methadone has to be picked up at a specific methadone clinic by a specific methadone licensed doctor. Those are the big differences, and the College of Physicians and Surgeons in Ontario guidelines recommend that if someone is on methadone or Suboxone, they should be getting counseling at the same time. So it's not just one or the other.
Right.
The idea is you don't have that withdrawal. We're going to make it so that you're not going to be sick every day, but let's start talking about why you used to begin with. And let's start talking about what's underneath that iceberg, right?
Exactly.
And start trying to prevent this from coming back in the future.
Certainly, because what's the good in treating the symptoms if you're not working on the root cause?
Exactly. Yeah.
And the way I kind of envision it when you're talking about Suboxone is kind of like a shield, sort of like when you say that it prevents other opioids from getting in, sort of. It's almost like a barrier in a way.
Yeah.
Versus the other with methadone, which, as you said, is like an opioid.
Yeah, it's a full agonist. And I'm not a scientist, and I don't.
Okay.
I'm not a pharmacologist.
You're great at explaining.
Oh, thanks. When I explain it to my participants, I always say Suboxone, which the opioid inside Suboxone is called buprenorphine. It's kind of like the big kid on the playground that's like, I'm hanging out here, nobody else is coming in, right?
Perfect.
Right?
Yeah.
And the other part of Suboxone, naloxone, is built right into it. So we get really confused with the terms and everything.
Right.
But naloxone itself, which Blair spoke about earlier, is built right into Suboxone in order to prevent tampering and to prevent abuse.
Excellent.
Yeah.
Now, and something else that I really liked that when you were describing the availability of Suboxone is that it's much more accessible, and because there is such a problem with stigma and people feeling nervous about their anonymity, right, going to a clinic, or and just the very bit of a burden that it is to have to get down to one of those clinics every single day, right? Like a lot of people, they may be low income, and so getting there and being able to afford transit to those locations might be difficult.
Right.
Whereas if they have a Shoppers or a Rexall right around the corner from where they're staying, it's a lot more accessible, and it puts them on a path that perhaps will be more successful because there are fewer barriers.
Right, yeah. And you think about, like I said, it takes a lot longer to earn those carry doses with methadone. So I may have a really good support system in BC, but I don't have carry doses, so I can't go out and be with those people until I earn those carry doses. So it does create a lot of barriers for people in order who are trying to recover and who are trying to move forward. Getting to work on time every day. The clinic doesn't open till 8 o'clock. Those are barriers that people face when they're trying to recover. So it's not simple. It's not easy. It's hard work, and I tell people all the time, it's hard work to recover. And the stigma, eliminating the stigma, is a significant part that we try to work
Totally.
with.
Yeah, because that is one of the biggest barriers, and being able to trust people to let them in when they tell them information about themselves, whoever it may be, having that level of trust with them, like, please don't judge me, that sort of thing. And that's a massive barrier for people. And even the different types of language that people use on the day-to-day, like there must be terms that are, instantly make people feel uncomfortable. Maybe share a little bit about that.
Yeah, so there are certainly terms that we don't use, and if somebody identifies to me that they are, whatever, I'm not going to use them because I don't like to read them, but
don't perpetuate it.
Yeah, I don't want to perpetuate it. Yeah, but we look at it in person-first language. So this is not the addiction. This is the person with the addiction. This is the person with the substance use problem. This is the person who had goals and dreams when they were young, just like everyone else, and got a little off course. And this is the person who deserves a chance at making change, and we want to be part of making that change with them.
Totally, because if you start talking about the addiction, it dehumanizes the individual who has this problem for right now, and it can be a temporary thing in terms of the immediate immediate, a lifelong, battle for some to try and stay on track with their goals and what they feel is right for their life. But yeah, totally, it can be really overwhelming, I'd imagine, to be trying so hard to make progress, and a comment that might be flippant from one person could really damage the progress that they're trying to make, right?
Right, absolutely. And I feel like addictions and people who are substance involved is one of those last few subcultures that we still as a society generally accept that stigma and speaking negatively towards them, where we don't in so many other cases. But you can use those derogatory terms when you see somebody on the street that you think is substance involved. People feel comfortable using those terms, and I don't know why, I don't know where it comes from, but I really believe that in order to make a change and support people, because a lot of substance use is about stigma. Like, if I'm feeling ashamed and guilty about my use because of what's being projected on me by society and the loved ones around me, I'm not going to come forward if I have a lapse or if I have a relapse.
Totally.
Right? And it's concerning when I think about, talking about naloxone and opioids specifically. We have to think about the population that we support of people who do go into residential treatment, who say, no, I'm done, and stop using, and how great that is. Go into residential treatment, what a high risk they're at for overdose. Because I don't know if anybody explained it, but with opioids, your tolerance decreases really quickly. Right? So if I go into residential treatment or jail, say I'm in for 21, 30 days, and I go back out and I have a lapse and relapse, because that happens, and I go back to what I was used to using, I'm at a high risk for relapse. And I think we need to, part of eliminating stigma is having those conversations about this could happen. We're not saying it's going to, but let's be honest about it and say it could happen. Let's be safe.
Totally.
Yeah, talk about naloxone.
And so when people are, they're listening to us and they're like, yeah, I want some more information either for myself or for someone that I know, where can they get some more information about your agency specifically online? Where should they go?
Absolutely online. It's www.addstv.ca. Or you can also give us a call, 519-673-3242. And if you want to talk about an opiate-specific question, the COPE team, which I'm a member of, is extension 281.
Perfect.
Intake in London, I said, is Monday and Thursday, 1 until 4. And you can always email intake@adstv.ca if you have any questions.
Perfect.
Yeah.
Well, Megan, thank you so much for being here today and sharing all of that wonderful insight with us. We really appreciate it.
Thanks for having me.
Now, our goal here is, as Megan was saying, was to give as much information and assistance as possible. Here are some bits of information about different organizations in our communities to help you out if you need it. Reach Out is a new 24/7 bilingual information support and crisis service. For more information, go to reachout247.ca. Ontario Addiction Treatment Centres are located across our region. For information on the area closest to you, go to oatc.ca. Addiction Services of Thames Valley has French and English services available. Everything is free and confidential. For more information, go to adstv.ca. Thank you so much for joining us today for this very special program. Fentanyl use and opioid addiction it's an emerging issue in some ways. It's gaining traction here in Ontario, but it's an issue that affects people across the country. Certainly we've seen the rise of it on the West Coast, but thank you so much for joining us, all to our guests as well. Thank you for sharing their time and their insight and just really trying to help us understand this issue a little bit more. And remember, if you yourself or you know someone who is struggling with opioid addiction or usage of drugs and they want some help, remember there are resources there for them to access and to start on a path forward. Thank you again to all of our volunteers, to Christine Teleski and John Payne for their work, and we wish you all the very best. Take care.